All right, chapter 12, we're going to talk about the pancreas. We talked a little bit about it with the liver and biliary system, but we're going to talk a little bit more about the pancreas. So these are our objectives. When we talk about the pancreas. So the pancreas actually is an endocrine gland and also an exocrine gland. The pancreas sits right below your stomach, near the liver and the gallbladder, and right there with your intestines. So the pancreas has three parts. It has a head, and then the body, and then the tail of the pancreas. The exocrine function is the pancreas is a main source of a lot of our digestive enzymes. So, like amylase helps with the digestion of starches, lipase helps with the digestion of lipids, and then we also have some peptidases, enzymes like trypsin and chymotrypsin that help us with the digestion of our proteins. And it also provides some bicarb as well that helps with our acid-base balance. But and that bile duct actually, the pancreatic duct and the bile duct join to the duodenum or duodenum portion of the intestine, and so that actually helps with our digestive process. Then the endocrine with the pancreatic cell, the cells, it makes insulin, and then the insulin is made in the beta cells, and then it makes glucagon, which is made in the alpha cells. So everybody's familiar with insulin and everything. The anther cells, the pancreatic anther cells, with lost that part. When the pancreatic enzymes are actually made in these cells, they get released into the pancreatic duct. They're in the inactive form. They don't need to be active until they actually get into the intestines where those nutrients are. If for some reason those cells or those enzymes those inactive enzymes get activated in the pancreas, you actually can have an acute pancreatitis as a result of it, because the pancreas starts to kind of digest itself. The enzyme starts to act on the pancreas. So we'll talk about acute and chronic pancreatitis, and then we'll also talk about some tumors with the exocrine and the endocrine part of the pancreas. And then diabetes, it is the most important disease because it's caused by an endocrine dysfunction in the pancreas with the insulin, and it regulates the metabolism of our carbohydrates and our lipids. So some of our causes for acute pancreatitis, more common causes, alcohol. Our more common causes account for about 95% of it. 80% are either linked to alcohol or milestones with acute pancreatitis, and then the other about 20% is we just don't know. And then there are rare causes where there's trauma, surgery, drugs, infections, like mumps. Mumps will affect your pancreas if you have mumps. The acute response to tissue necrosis, it's caused again by those enzymes generally released a little bit early and become active in the pancreas. So when we have acute pancreatitis, we can either have like bile stones or alcohol, increased demand, overeating. That's usually when we get our patients with type 2 diabetes. It's because basically they've been eating too much sugars and things like that. And so the pancreas is working double time, overtime, trying to actually release enough insulin to bring down our blood glucose. And then as a result, the pancreas just gets to a point, it's like, I quit, done. And then those patients become insulin dependent. So we'll talk about that a little bit later. Again, those activated enzymes can actually cause necrosis of the tissues. And these patients, even with the overeating, we can also see hyperlipidemia, where we have our elevated lipids. And then so it's not just sugar, but also elevated lipids. Then the pancreas tries to get more lipase out there to help break down those lipids. So either way, you're kind of working everything over time. So we can see fat necrosis. We can also see calcifications, decreased calcium level when we have acute pancreatitis. We can also have ascites fluid as well. And then we can have something called steroperitonitis, where it's non-infectious. So you have that inflammatory process, but it's not due to an infection. And then we, of course, shock from blood flow, lack of blood flow. It can be abscess or, chronic pancreatitis or sometimes diabetes. So we have here a picture of a pancreas, and this is actually a hemorrhage in the pancreas, and it's very swollen. So there's a bit of hemorrhage in the pancreas. And then here we actually have some necrotic foci areas in the pancreas here. This is normal tissue here, but this is necrotic. And so with acute pancreatitis, you can just have some swelling. Usually it's bouts of nausea and vomiting. So you have the swelling, and with the swelling of the pancreas, the duodenum or duodenum portion of your abdomen gets compressed. And as a result, you get real nauseated because your digestion basically shuts off your digestion because what's in your stomach can't get past that area. And so it can cause nausea and vomiting. That's usually what people with acute pancreatitis will have. They can also, of course, have pain and things like that. But if you have like a release of those enzymes and you get those amylase, lipase, trypase, you can have fat tissue necrosis, and that can lead to the calcium being moved into that area. So it's decreased in your bloodstream. And the blood vessels, you can go into shock because you can start to see blood clots like we saw before. And DIC is called disseminated intravascular coagulation, where your body is uncontrollably moving between bleeding and clotting. And then that can lead to shock if you bleed too much. And that ultimately can lead to death. And then you get in the peritoneal cavity, you can end up with peritonitis, which could then become infected and cause death. Or if you have destruction of the pancreas, it can lead to the pancreas to rupture. If it has a pseudocyst or an abscess that gets large enough, but either way that can lead to death. But you could have like a malabsorption with a chronic pancreatitis because your pancreas is not releasing the enzymes that your body needs to digest things properly. And in those cases, you will usually have to orally take those enzymes when you eat to help it digest to get the nutrients. So chronic pancreatitis most often is caused by chronic alcoholism. It can be some trauma, and you end up with fibrotic material replacing your normal cells. It is progressive. It is irreversible. And then you not only have issues with the exocrine function, but you also have a issue with the endocrine function. We typically will see the chronic pancreatitis more in men than women. And so this is a pseudocyst. This actually is a fibrotic sac here, and you can actually see some fibrosis here. And this is actually after it's been drained. And so it's made the pancreas extremely enlarged. And then that's the liver there. So with chronic pancreatitis, it's a gradual or insidious onset. You typically have pain in the upper quadrant. It radiates around to your back. And it's usually after eating because that's when your pancreas is trying to release those enzymes. I mentioned before malabsorption because of enzymes. If the pancreas is not functioning properly, it cannot release those enzymes to help break down those things like your fats and your proteins and things like that. So, and that happens because the anthiner cells in the pancreas are so damaged, the digestive enzymes just simply aren't produced. And so what happens is things get passed on through into your stool. One of the things that we can see in the stool is like fat in the stool. Instead of them being broken down by lipase, they get passed on through your GI tract and into your stool. You end up having fat, and that's called statorrhea, STATORREHEA. Then we can also have we can have the calcifications, and that calcification can actually be indicative of the destruction of other cells in the pancreas. But the course is relentless. Again, it doesn't reverse. Stopping the drinking can help some symptoms, but it doesn't solve the problem. When we have tumors and looking at tumors, most of them are involved in the exocrine side as opposed to the endocrine side. Most of them are usually going to be solid. Usually If we find a pancreatic cancer, it's usually going to be malignant. And then we have some that can be what we call functionally silent. And that's because the cells that are affected actually don't produce either hormones or enzymes. So it doesn't produce an effect on something else. So they call them functionally silent. So the most common tumor or most important tumor involved in the pancreas is adenocarcinoma. It's fourth leading cause in death in men, fifth in women. Smoking increases risk. If you've had chronic pancreatic pancreatitis, it increases risk. Usually it increases risk with age over 40. Poor prognosis is usually very poor. Usually they die within 2 years. Most of the time, the cancer is going to be at the head of the pancreas. So of course, they want to cause issues with the bile duct as well. So they'll usually have digestive issues and things like that. Then 25% will be all over the entire pancreas. The tail is usually the least, where you would be least likely to actually find that adenocarcinoma. And then when you look at it under the scope, we can have what we call well-differentiated. All of this is adenocarcinoma. Then we have what we call moderately differentiated. You can still kind of see, some of the lumen of vessels and things like that. But then the undifferentiated, it's getting really bad. So prognosis is worse and worse with these. Metastases is common very early in the disease. Usually it will go to the lymph nodes about 40% of the time. Another 40% of the time it goes even further to distant metastases. And only about 20% of the time does it stay in the pancreas, which is why it's very important, because that 20% of the time it just, it's only in the pancreas. That means 40% of the time it's going somewhere else, or 80% it's going somewhere else. So these patients will see, it depends on the location of the tumor, its size, and the extent of the spread. And we will typically see weight loss of appetite, and nausea, especially if it's in the head of the pancreas. We see jaundice if it's in the head of the pancreas, because it blocks the common bile duct coming into the intestines. Cavassier sign, it's distension of the gallbladder. We can also see that. If it's you're more likely to have more pain if it's in the tail of the pancreas. Again, I mentioned before, metastases is common, usually the lymph nodes and liver. And then you can have, we can actually look, the test we would do is ERCP, and it's very important with the diagnosis. Then we have some other types of tumors that deal with the endocrine pancreas, and it comes from the endocrine cells in the islets of Langerhans. It's 10 times less common than exocrine, but we can still have them. Like an insulinoma is actually most common, and then what happens is these cells actually secrete insulin. And as a result, you have hypoglycemia, syncope, like you profuse sweating, and it's kind of the same symptoms like your blood sugar drops, and you get a little, you pass out. You just give them glucose. Gastronoma is benign, low grade. It can be hormonally active. Gluconoma, these are less common. Somatostonoma, viapioma. These are usually malignant if you find them, especially like the MIN1. If you find that, that's multiple endocrine neoplasia syndrome type 1. Essentially, it's multiple tumors, multiple malignant tumors found over, and it involves different organs. So I think I've mentioned some of this before with the pathology of chronic pancreatitis. We have fibrosis of the pancreas, so that normal tissue is replaced by fibrotic tissue. We can have atrophy, and then we have loss of those enzyme cells. So we lose some of that endocrine and exocrine function. We can have stones, we can have calcifications. Usually, the islets of Langerhans cells are actually okay initially, but late in the disease, they can still be affected and replaced by fibrotic material. So this just kind of shows you like some of the stones, and also calcifications, pseudocysts. And with the formation of these stones, you can have the pseudocysts, calcification. Then you can have fibrosis in the tail. Remember I said you're more likely to have pain if it's in the tail of the pancreas. And it's because the nerves get trapped in that fibrotic material. So now you have some nerves involved. And so that actually makes the pain worse when it's here in the tail of the pancreas. So this is calcified, like these are calculi, calcifications and the duct is very dilated here. And then we also have fibrotic material. So this is fibrotic material here, fibrosis here, and then these are the ducts, and the ducts get narrowed because all of this fibrotic material around them. And so we'll finish up talking about diabetes. And with diabetes, there are two different types of diabetes. Well, there's more than two types, but we're going to talk about type 1 and type 2. Diabetes mellitus or mellitus is what we call like the sweet, which deals with glucose. We could also have something called diabetes insipidus, and that deals with hormone as opposed to glucose. We have type 1, which is insulin dependent, and then we have type 2, which is our non-insulin dependent, and we'll talk about the differences. And so it can then be secondary to other diseases. And it's either the consequence, either an absolute or relative insulin deficiency, or you have enough insulin, but you have what we call insulin resistance, meaning your cells won't react to the insulin that you do have. So when we look at type 1 versus type 2, usually type 1 is actually due to an antibody to the cells that actually make your islet cells. And so those people are dependent on insulin. Type 2 is usually linked to things like oral contraceptives, but diet, exercise, things like that. Type 2s usually end up being insulin dependent because usually they're not compliant for a long time. And by the time they get compliant, they have damaged their pancreas to the point that the pancreas is no longer making insulin. And so they become insulin dependent because of that, not because there's a, like type 1s can't help it. There's an antibody there. Doesn't matter what not say it doesn't matter. They can have the perfect diet and their body, they're still not going to make the insulin they need because there's an antibody. Type 2s, you can look at a different of the build. With a type 1, it's usually sudden, like all of a sudden your glucose drops. You usually find this in people under 30 years old. We had a young girl at our school. She was in pre-K when they discovered she was a type 1 diabetic, and it was because her glucose was bottoming out at school. Patients that are type 2 are usually obese. There's a more family history of it. Twin coincidence is higher, less with type 1 with family history. Antibodies, you will have those antibodies to the islet cells in type 1. You will not have it in type 2. It says here serum insulin level is low in type 1 because, again, due to the antibodies. It says normal in type 2. That's initially. It would be normal, but as it goes on, the insulin level drops because of damage to the pancreas and overworking the pancreas. And treatment, type 1s have to have insulin. They're usually on an insulin pump. Type 2s, you can correct it with diet, exercise, oral hypoglycemics, things like that. You just have to be very careful. So with hyperglycemia, there's some pathogenesis to it when you have an elevated amount of glucose. So it could be due to any of these reasons, okay? The insulin resistance, your body has an increased demand for insulin because you're overeating, or there's an issue with the antibodies. But with diabetes, you have increased glycogenolysis, which is breakdown of glucagon into glucose. Then that causes hypoglycemia, which then causes polyphagia. Polyphagia is like an increase in your appetite, and then it causes glucose urea. Then it causes polyuria, which means you urinate more and more. Then that causes polydipsia, which is increased thirst. Usually how people start realizing they have diabetes, like they're so thirsty all the time, and then they're going to the bathroom a lot. And so what your body's trying to do is decrease your glucose level by getting rid of it through urine and then making you drink more so you get rid of more through urine. So that's usually what happens. The polyuria can actually decrease the volume or cause volume depletion, which can then make that glucoseuria worse. And then it causes hyperosmolality. So basically, if you've ever like had like a sweet drink that had so much sugar in it, it like almost was thicker, like in the because of the number of solids in it. It's kind of that kind of thing with your blood as well. And then you can also have increased lipolysis, and lipolysis is a breakdown of lipids, and this is where we get into trouble because then free fatty acids are increased in the blood, and then they form ketones, and then the increased ketones will create what we call ketoacidosis. I know that there are a lot of diets out there that want to try to induce ketoacidosis. And the reason they want to try to induce ketoacidosis is your body is actually breaking down fat cells in order to do it. Problem is, ketoacidosis can put you in a diabetic coma. So you have to be very careful with those types of diets that are trying to, induce a ketoacidosis. It's doing it because, yes, it's breaking down fat cells. So, yes, you could lose those fat cells. But if you take it too far, you could end up in a diabetic coma. So you have to be very careful. And so this is just showing the islet fibrotic material in those islet cells with a type 1 due to the inflammatory response from the antigen antibody reaction. There are a lot of complications that lead to some of the comorbidities that come along with diabetes, particularly like type 2. So it affects your heart, kidney, eyes, nervous system, especially if it's uncontrolled or inadequately controlled. Most of the morbidity and mortality with diabetes comes from the cardiovascular issues. It can cause arteriosclerosis, causing gangrene in the extremities, where the patients have like diabetic or peripheral neuropathy. Arteriosclerosis, it can also work your kidneys. Your kidneys only have the ability to filter so much glucose at a time. So, and it's usually around 180 milligrams per deciliter. So if you are diabetic and your glucose is running 300, that means your kidneys are running at max capacity trying to filter the glucose. Eventually it causes damage to the kidneys. And then that's why the diabetics end up on dialysis. Then it also affects them because these patients can have glaucoma. They can also have what we call retinopathy. So in the back of the eyes, they actually can start having little bleeds in the back of the eyes. And so that's how diabetes can also cause blindness. And then, of course, the nervous system, like with the cerebrovascular disease, so it can cause some issues in the brain, but it also can cause that peripheral neuropathy where like they can't feel their feet. They can't feel their extremities. It's usually the feet first because they're the furthest away from the heart. But it can cause, you can have stroke. You can have a narrowing occlusion of the veins that can cause gangrene, that neuropathy. You can also have occlusive arteriosclerosis, where in the glomerulus, it starts to actually occlude the vein and then causes issues. And in the glomerulus, the basement membrane gets really, really thicker, and then it causes some issues as well with diabetics. So and again, in the eyes, you start to have these little microaneurysms or hemorrhages, and you end up with the fluid buildup in the eyes, and that fluid buildup in the eyes ends up with glaucoma. Then they can also have cataracts, and so it's just a very debilitating disease. And unfortunately, some of these things that happen are happening and the patient doesn't know it. So they're living their best life and they're non-compliant or minimally compliant. And then they get to a point where the damage is done and it can't be reversed. Some of it can be reversed, but they have to catch it and get on a diet and get under control.